Did you want me to just start, Linda?
No, go ahead, Sinan and Christine. Do you want to introduce Dr. Hershow?
Yes,
Yeah,
Christine, gonna start.
yeah, I can start. Can everyone hear me? Hey
Yeah.
Yeah.
everyone, I'm Christine. For those that don't know me, I'm a Epi PhD student here, and I and as well as Sanan will be moderating today's session on the epidemiology of COVID-19. So our presenter today is Dr. Ronald Hershow, who is the director of the Division of Epidemiology and Biostatistics here at UIC, and an MD specializing in infectious disease. He has a lot of incredible research focused in various infectious diseases, but his research recently has centered on COVID-19 as it affects congregate living settings that include long-term care facilities, homeless shelters, and most recently, college dormitories. So I know he has a lot of unique insight for us today as he presents on some of the epidemiological factors related to the COVID-19 pandemic. So as Sanan mentioned, if you have any questions throughout his presentation, please keep your microphone muted and just ask them in the chat box. And we will monitor the chat box throughout his presentation, and we'll wait until the end to ask him any questions. So with that, I guess I will go ahead and pass the mic over to Dr. Hershow. Thank you for being here, Dr. Hershow.
Thank you for that nice introduction, Christine. It's really great to be part of this course, and thanks to Dr. Forst for organizing it and creating such a stimulating series of lectures. So I'm going to talk about COVID-19 epidemiology, which is a big subject, of course. And I fully anticipate that the most interesting part will be the question and answer session at the end. But I'll get us started with some slides, and I'll get started now. So it's hard to believe right now that it was only last January when I was teaching my class on terrorism as a public health issue, and as so often happens in that class, there's some natural outbreak that happens, and we get to make the point over and over that nature is the best terrorist. And so there was this news item about a new coronavirus that was circulating in central China in the city of Wuhan. And, we actually talked about it in the class. We invited a Chinese national who was in the College of Pharmacy, who had a lot of contacts back in China, to give a talk on it in the class. And of course, it proceeded to expand from those initial um, um, news reports that we heard. And what's interesting looking back is this is one of the first slides I made about this new coronavirus, and it was very early. At this time, the denominator of cases was 99, and at this point, nearly half of them had had exposure to a seafood market, an exotic meat market in in Hunan. And we already were starting to get some reports about this first group of cases, and you can see the average age and the male-female distribution. What's interesting to me looking back now is that all of these symptoms have remained accurate, of course, but now we have discovered that COVID is a multi-system disease, and that it affects virtually every organ system in the body and in various ways. And we have yet to really, I think, fully grapple and understand the long-term consequences of COVID-19 infection. But these symptom lists remain as true today as they were in January when I made this slide. And this is also a very early slide derived from an early New England Journal article, and featuring some early data about this evolving epidemic in central China. And what I find really interesting about this is that the can you see my pointer? Yes.
No.
I cannot.
Oh, okay. Well, I think I have to do this then.
We
Now
can
we
see
can.
it now, Dr. Hershow.
Okay, thank you. I usually use Zoom, so this is a little strange to me. But anyway, so what we can see here is that some of these early calculations about the reproductive number of the first Chinese cases being around 2.2 remains pretty accurate. This is about where most estimates of the reproductive number. We'll talk about what the reproductive number means in, I think, the next slide. But this calculation has remained remarkably accurate. The one thing that did change is that when we were looking at the early case fatality rate of COVID in these early cases, it was a whopping 4%. And that has not proven to be true over time. But early in an emerging infectious disease, there's often a bias toward the most severe cases. And I think that's what accounted for that distortion. We can see that this reproductive number of 2.2 is a substantial reproductive number. This is a measure of how communicable the disease is. And we can see that there are diseases like measles that have this dramatically larger R0. And then if we compare this to influenza, seasonal flu, that might have about a 1.4 R0. So this seemed to be a little bit more contagious than influenza of the seasonal variety. And that has proven to be largely true over time as well. But this number was inflated, and it was inflated because we were just seeing this tip of the iceberg of reported cases, and there's a bias early in an emerging infectious disease where the most severe cases, the hospitalized cases, tend to dominate the early reports, and therefore you see a higher case fatality rate. Over time, that initial measure of case fatality at 4% has come down. We now feel it might be as low as 0.1 to 0.3 as a case fatality rate. And we probably really don't know the full case fatality rate because we don't know the full denominator of cases because we've now discovered that many infections are asymptomatic and don't ever get counted. So this is that definition of the R0 or the reproductive number, and it's the average number of second cases that will arise from an average primary case in an entirely susceptible population. And this, as I said, is a crude number of the communicability of disease in human populations. And it does matter, of course, with how quickly the disease will amplify and spread. A disease with an R0 of 2, and remember that COVID has one of a little over 2, doubles in generations of cases. Higher reproductive numbers yield larger number of cases as generations of cases ensue during any outbreak. So another thing early on that we started to realize was the importance of asymptomatic transmission in this evolving, what came to be called the COVID-19 outbreak. And it's, I think, instructive to compare it to the 2003 SARS epidemic, which was also a coronavirus epidemic, also started in a food market. But in contrast to our current experience with COVID-19, the first SARS outbreak in 2003 was controlled after eight months. A total of 8,100 cases occurred in limited geographic areas. It was a pandemic because those areas were scattered across the world, but it was a very, ultimately, a limited pandemic. Contrast that with COVID-19, with which we've now had about 8 months of experience with it. And in that 8 months, COVID-19 has caused 25.1 million infections and 844,000 deaths globally. So how could two coronaviruses behave so differently? The main reason is this importance of asymptomatic and mild disease with COVID. You know, on the face of it, you might say, well, I like a mild disease. Um, the first SARS had a case fatality rate of 10%. That's a scary case fatality rate. But because the disease was more invariably pathogenic, that is, if you got the disease, you developed symptoms, it was easier to find cases, to isolate them, to institute careful infection control when they were admitted to hospitals. And that was really what was responsible for the ability to control the disease in less than a year. With the new SARS epidemic, that is not the case. Peak viral shedding coincides with symptom onset. Well, here I'm talking about the original SARS, I'm sorry. Peak viral shedding coincided with symptom onset and peaked when the level of symptoms are also at their peak. With COVID-19, there are high levels of viral shedding in the upper respiratory tract 2 days before symptoms begin, which is different than SARS-1, where the viral shedding begins after symptoms begin. And viral loads can be very high, even in the presence of asymptomatic infection and mild illness. So this is a disease, because of its mildness, that allows infected people to continue to circulate in their communities and spread the disease to other people without being sometimes symptomatic, and with being so mild that they can shrug it off and continue to circulate in communities. And therefore, because of this high importance of symptom-based precaution, of asymptomatic infection, symptom-based precautions don't work as a mechanism to control this disease. And that sounds easy. All this is easy to say, but it's such a fundamental difference that it translates into this dramatic subsequent epidemiologic spread of COVID-19 compared to the original SARS epidemic. We started to learn about this potential for asymptomatic spread early on. You'll recall that COVID was thought to have made first landfall in the United States in Washington State and Seattle, and there were some early outbreaks in a skilled nursing facility. And this particular outbreak occurred, involved a healthcare provider who continued to work in the facility while symptomatic. He subsequently tested positive for COVID-19 on March 1st. And then the facility conducted 2 facility-wide prevalence surveys 2 weeks later and 3 weeks later. And in this sero survey, among 76 residents, more than half, or 63%, tested positive. Of the 48 who tested positive, 27 of those were asymptomatic. So more than half the cases, even in elderly residents, were asymptomatic. And worryingly, the quantitative viral loads for the asymptomatic and symptomatic persons were roughly equivalent, showing that high levels of communicability were present even among those with asymptomatic infection. What these results indicated was that asymptomatic infections were playing an important role in the transmission of COVID-19, and that this reality turned out to be particularly important in congregate settings like prisons, homeless shelters, summer camps, and dormitories. And basically, this kind of finding about the importance of asymptomatic transmission has been replicated in a variety of countries, in a variety of contexts and settings, and it is part of the reality of COVID-19 that enables this disease to continue to spread and to evade contact tracing efforts and other efforts to control infection. And it is why it's so important to wear masks, because the assumption has to be that anyone out there could be carrying COVID-19, not just the symptomatic. So given the importance of asymptomatic transmission, it's particularly difficult to understand why recently the CDC announced that they were going to discontinue the recommendation that asymptomatic contacts of cases of COVID should be tested for COVID-19. And you've probably been following this controversy in the news over the last several weeks. It's again part of what I consider bad leadership. That this kind of recommendation is being released and perhaps stimulated at the highest levels of our government. So getting back to the story, from that initial point source in Hunan, the disease quickly spread rapidly around China, and then began spreading elsewhere in the world. And this is, again, shows the disease making landfall in the United States, in Seattle, and later in California. What we didn't know, of course, was that pretty much concurrent with this, the disease was spreading from Europe to the United States. In fact, the European strain proved to be more communicable, not more virulent, but more communicable than the Asian strain. And it ultimately became the predominant strain in the Western Hemisphere. So this was going on, and eventually, fast forward now to a recent WHO map of COVID, and now we have over 25 million global cases and 844,000 deaths, and we now have hotspots in North America and much of South America, and you've all lived through this history, so there's no need for me to belabor it. Within that, it's important to note that the Western Hemisphere has dominated the global epidemic. The Americas are noted in yellow on this figure, and you can see the dominant role of the Americas in the incidence of COVID-19. There was a period where Europe was very important, and there was, of course, that period where China was important, but they did a very dramatic job in controlling it. And from March onward, really, we see a different picture emerging with, again, the Western Hemisphere dominating. Within this global picture, the country that has fared the worst with COVID-19 is the United States, and we can see on this figure this dramatic buildup of cases to we're now over 5,866,000 cases. These figures become obsolete as soon as you make them. I think I got these data 3 days ago, so we're undoubtedly higher now. Basically, we've had shifting hotspots in the United States. There was that moment where New York was the hottest place in the nation. That has given way to other hotspots more recently, and Texas and Florida have featured prominently in that story. And how did we get here? How did we get to the point where the wealthiest country in the world, with perhaps the world's preeminent public health organization, the Centers for Disease Control, became the single worst affected country in the evolving pandemic of COVID-19? I guess just before I start embarking on an explanation, it has to be acknowledged that this represents a vast and tragic failure on the part of our leadership on this issue in this country. So we got off to a bad start in the United States. Our testing program was delayed when the CDC developed and distributed faulty test kits. You'll probably all recall this story. They then failed to approve the World Health Organization tests, or those developed by local public health labs. The testing program has been plagued by shortages of reagents, materials, PPE, and even the swabs that are used to gather specimens at various points. And the fact is that we're still not there with our testing program. We're still not doing enough testing, even though in sheer numeric testing, we are doing an impressive number of tests, but not enough to really keep track of this epidemic in the granular way we need to really control the American epidemic. And we can see that, since March, we have had a buildup in the number of tests per day in this country. This figure stops in early May. But beyond just this crude number of tests, which is something that, our president likes to mention, the sheer number of tests that are being done every day, and point to the fact that it's more than any other country. But it's important to note that our best database on COVID-19 was created through the efforts of news media organizations and contains only limited data on the number of tests that are being performed. Although we can give you the crude number of tests that are being done, we lack data on comprehensive data on which racial and ethnic groups are being tested. The characteristics of persons being tested is largely unknown. Where people are being tested is largely unknown. How people are being selected for testing is unknown. And the turnaround time, which is a key metric, is also unknown. To do effective contact tracing, you have to reach contacts within 48 hours, generally speaking, to really have an impact of getting those contacts into isolation before they can incubate the disease and move it forward through transmission. And we still don't really measure this in any way. Although anecdotally we hear that tests still take 4 days, 7 days to return to people who are being tested. So I'd like to switch now, and I'm going to take a moment to toggle to the COVID-19 CDPH dashboard. Just wondering how I do that. I think I got it. Sorry about that. Okay, so we are blessed to have a really great dashboard that was created in CDPH. Believe it was actually created by an alum of the School of Public Health, Nick Pershan, and it is really a marvel. You can get lost in this dashboard. It has so much data at your fingertips, and it is publicly available. You just have to Google Chicago COVID dashboard. And what we can see here is that our Chicago epidemic peaked in the positivity rate. Positivity rate is the proportion of COVID tests that are performed that turn out to be positive, that is, that indicate COVID infection. And we can see that the positivity rate peaked at about 30% in April and May, and then it has decreased. The WHO has advanced the idea that a society may be able to reopen when the positivity rate in their community sinks below 5%. And you can see during the summer we reached that threshold, although recently we've started to creep above 5%. And as you'll see here, we're currently at a positivity rate of 5.3%. So we have to keep our eyes on that. If we look at some other data regarding the Chicago epidemic, we see that here we have incidence curve, and these are rates that are per 100,000 population. And again, you see that our epidemic peaked in really in April. This single largest case day was April 23rd, when we had 1,471 cases on one day in Chicago. And since then, we've had this nice declining pattern. Then we hit the summer. Remember, we were anticipating a summer respite, but in fact, incidents started to creep upward during the summer. And if we now go to a different metric, a different but very important metric, which is death rates, we can see that, remember that case occurrence peaked on April 23rd. Our highest day of deaths is May 5th, when 57 Chicagoans succumbed to COVID-19. So there's sort of a 2-week lag between the case incidence rate and the death rate. We see that demonstrated here. The reason is that when you develop COVID, it takes you about 2 weeks to get sick enough to have a chance of dying. And that's why deaths always lag a little behind incident cases, at least temporally speaking. But this is a very crude statistic. One thing to note is that even though during the summer incidents began going up in Chicago, the death rate happily remained fairly flat in Chicago, and maybe we can figure some things about that out by looking at some other data. But really, this crude death rate doesn't begin to tell the story of what's really going on in this outbreak. And what we have here is these incidence rates sorted by race, ethnicity, and the purple line is African Americans, and the blue line is Latinx populations. And even though these are minority populations, we can see that they are dominating the death rate statistics for COVID-19 in our city. This is perhaps even more apparent on the crude case count in data, where we can see the purple and the blue dominating the case counts in throughout our epidemic, really. And that reality is, I think, part of why we all go into public health, to identify these kinds of health inequalities and then try to do something about them. I mentioned that thing about how even though incidence was going up in the summer, that 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 death rates stayed flat. Perhaps we can get an answer by looking at the age-specific occurrence of COVID, and we can see that during April and May that it's really the elderly populations. These are the people greater than 80-year-old, the 70 to 79. These were the dominant part of our early epidemic, and you will recall that during this time, COVID was ripping through our nursing homes in Chicago and wreaking havoc in those settings. But that more recently, we have seen the rise of other risk groups, and we can now see, if we look at the case counts that are dominating our current epidemic, that that it's really the 18 to 29-year-olds and the 30 to 39-year-olds that are dominating our case occurrence. So that may explain why mortality hasn't gone up, because these age groups don't tend to die as commonly as the older age groups do, and yet they are dominating the incidence picture. Should have switched to incidence. So in the incidence data, you can see that the maroon kind of line, which is the 18 to 29 group, is now the dominant group. You can even see that a little more dramatically on the case data. So this shift of epidemiology, where early on it was the elderly groups dominating the epidemic, and later on it was these younger age groups, may explain why we haven't seen a rise in mortality, even as we've seen a rise in incidence during the summer. So let me go back here and you all see these slides now?
And I see a lot of duplicate screen.
Okay.
This is much better.
Okay, now I got to go back to where I was. Okay. Oops. Okay, no more toggling. Okay, so we just started dwelling a bit on the contextual analysis, on the disparity question that that not only in Chicago but all around the United States, there has been this disproportionate burden of COVID-19 incidence and mortality that has affected communities of color around the United States. The danger of just simply looking at that disparity and not delving into it and not doing a deep dive into it is that at times there might be mistakes made. Those mistakes might include attributing biological causes to these disparities, or behavioral causes such as adherence to prevention strategies as explanations for these disparities. So what we might enter into is a sort of a racialization of the COVID epidemic without attention to root causes that are really driving our American epidemic. There are postulated reasons for these higher death rates in minority communities. Some of them are listed on this slide. They include lack of access to health care and health insurance, and the fact that that leads to higher prevalence of less well-controlled chronic illnesses in our minority populations. And we have observed in this outbreak that COVID takes a particularly severe toll on people with comorbid chronic illnesses like obesity and hypertension, and diabetes, chronic obstructive pulmonary disease. Other postulated reasons for these health disparities are that non-medical threats to health are also higher in minority communities, food and housing insecurity, and exposure to toxic environmental circumstances. There's also been postulated the reality that often minority communities are engaged in riskier types of occupations, such as providing care at the long-term care facilities that have been a hotbed for COVID-19, and a greater likelihood that minority individuals will get their care in safety net facilities, may be overwhelmed by COVID-related surges. We've seen this very dramatically in New York, that the public hospitals got overwhelmed a lot more than the private hospitals, and due to staffing concerns and so forth. To guard against these any mistaken conclusions about COVID-19, we must couple these kinds of data that we saw on the COVID dashboard for Chicago with socioeconomic markers and indicators of economic inequality. We also have to unpack some of this and understand the effect of weathering or advanced aging caused by bodily wear and tear, responses to external stressors, and especially racial discrimination in our minority populations. And we need to understand the unequal distribution of COVID testing itself, preventive services, respiratory hazards, and toxic sites, and environmental injustices. And we need to fully grapple with inequities in food insecurity, housing instability, and limited access to transportation. I think there are potential solutions to these inequalities, but many of them are not easy fixes. We need to change policies that keep structural racism in place and promote education on how the health field perpetuates social inequalities and how that relates to health disparities. We need new policies to increase economic empowerment and educational opportunities in our low-income communities. We need to build community programs that build stable and supportive structures as part of our pandemic recovery efforts. And I know as the School of Public Health is involved in launching an army of helping CDPH launch an army of contact tracers in Chicago. And part of the benefit of this program is that it partners with community-based organizations and builds up their capacity and their infrastructure to engage in these kinds of supportive health kinds of work, and the hope that we can continue that kind of work even after we gain control over COVID. So we need, our health systems need to build trust in our vulnerable communities to counteract generations of mistreatment, unethical experimentation, and criminal neglect of minority communities. And we need to target interventions to address specific social risk factors. So no talk on COVID epidemiology would be complete without talking about the important place of nursing homes in COVID epidemiology. I think that has been apparent to all of you. Basically, across the United States, thousands of facilities have been reported outbreaks among residents and staff in these kinds of nursing home environments. And although less than 0.5% of the US population currently live in homes, that's about 1.4 million people, nursing home residents have accounted for fully 1/4 of COVID-19 deaths in the United States. And in the US, 41% of all COVID deaths and 8% of all cases relate to nursing home cases. And in fact, in 20 states of the United States, nursing homes account for more than half of these deaths. And by the way, Illinois is one of them. We can see that on this map that the red states are those where more than half of the deaths from COVID relate to nursing home deaths, and Illinois' figure is 53%. Some states have even more dramatic percentages than that. So why were nursing homes such a perfect environment for COVID, and why people use the phrase perfect storm a little too much, but I think it is apt in the case of nursing homes, because in nursing homes we have staff who may be asymptomatically infected and may work at multiple facilities. What we found is that nursing home staff frequently have affiliations with more than one nursing home. Infection control expertise within these facilities may be limited. It's gotten better as the epidemic in the United States has progressed, but early on it was quite limited. Within nursing homes, the basic programming for the residents features congregate activities and common dining that again would facilitate the spread of COVID in those environments. In addition, there was wide-scale shortage of personal protective equipment in nursing homes. And within nursing homes, COVID testing programs were slow to be initiated and were draining on the limited and depleted staff in these facilities. Many staff were furloughed home because, in fact, they were infected with COVID. And another reality is that generally nursing homes are filled to capacity, which made isolation and cohorting strategies within those facilities difficult. So all of these issues did create an environment where COVID could flourish, and it unfortunately did flourish. There's another economic reality here that nursing homes tend to admit two basic types of patients, two groups of patients. One are the short-term post-acute care patients with Medicare coverage, and Medicare is a generous payer. So from a nursing home points of view, this population is their money-making population and subsidizes the second group, which are the long-term residents who tend to be covered by Medicaid, which pays below the cost of care. However, once COVID began penetrating into nursing homes, few nursing homes were admitting these short-term Medicare recipients because they had rip-roaring outbreaks of COVID going on in the facilities, and many of them are, as a result, facing bankruptcy. And these are realities that are, these are vulnerabilities that we've identified in the way nursing homes work in this country. So what are potential solutions to these realities? Well, the biggest intervention, I think, that has begun to control outbreaks in these facilities are accurate and rapid COVID-19 testing surveillance programs, adequate personal protective equipment, and strong infection control practices in these facilities, and ensuring that these post-acute care patients that now can't be sent to nursing homes have a place to recover is a sort of a healthcare service delivery problem that the United States is grappling with. It's clear now that hospitals will need to support and be accountable for post-acute care delivery, at least for the foreseeable future, and probably like many changes that are occurring due to COVID, this will become a permanent change in our healthcare environment. So a lot of my recent attention has focused on another congregate setting we call nursing homes and homeless shelters and prisons, congregate settings, because people reside there and there are opportunities for the disease to spread dramatically in these living circumstances. But the latest one that's garnered my attention has been dormitories. And of course, UIC is now undergoing a reopening, like many college campuses. This was a New York Times article. This was a figure from a New York Times article that that was done just a few days ago, really, on August 26th. This was in the New York Times. And it was a survey of 1,500 American colleges that revealed that even really August 26th is before many colleges have even dramatically reopened. And yet there had already been 26,000 cases linked to universities and colleges, and fully 64 deaths since the pandemic began. There were some colleges that were affected dramatically. The red dots on these figures are those with more than 100 cases. We can see University of Alabama at Birmingham had 972. I think you probably all have heard about University of North Carolina, Notre Dame, and Michigan State. I could have added to this list as well as being severely affected by these college-based outbreaks. And in UIC, we're having, I guess, what you would call a scaled-back reopening. Our normal student census at UIC across the health science colleges and the undergraduate campus is 33,000 students. But the fall reopening that we have just recently begun is, as I said, scaled back. We are not absolutely certain of this number, but we estimate that there will be 11,000 students who will physically touch our campus in this fall, and 7,000 employees who will physically touch our campus. In the School of Public Health, we've made a decision to be almost 100% to use remote education or distance education, online education, but the undergraduate campus is frequently using a hybrid model, where can learn at a distance, but some are availing themselves of in-person, in-class education. To try to protect our campus, we've initiated a social compact with our employees and students. The idea being that we consider it a civic responsibility to help to protect each other and the UIC community. And this, of course, avoids all of these measures that you're all too familiar with, like social distancing, avoiding crowds, hand hygiene, and face masks. But another thing it involves that you may not be as familiar with is this idea of a surveillance testing program. This is a form of COVID testing that is done for public health reasons. It's not the kind of testing you would receive if you developed symptoms of a respiratory illness, you went to your doctor and they tested you for COVID-19. This is testing that's done on asymptomatic persons, and we have now entered into a pilot period where we're testing what we deem to be the most vulnerable, highest risk populations in our university weekly at a rate of about 500 tests being done a day. So who are those high risk groups? There are dormitory students that number about 1,400 of these 11,000 students. There are students, student athletes who number just over 100, and there are performing arts students. Performing arts students are at risk because they project with their voices or blow through musical instruments, things that aerosolize virus, and frequently they're engaged in sort of congregate activities that involve, for example, performing a play or something like that. With that engine generating positive cases, we're seeing about a test positivity rate of about 0.6 to 0.7% so far. We have implemented a contact tracing program that is based at the School of Public Health, and we have hired and trained our first group of 7 contact tracing students, and they are the first day where they were actually doing contact tracing was Monday of this week. They're already doing a magnificent job. Several of them are first-year students, and I don't know, it just makes me really proud to see how they've risen to the occasion and have been engaging in this contact tracing activity. So I think I wanted to leave at least a half an hour for your questions, and I think I'll stop now and open it up to our moderators and the question and answer session.
Well, thank you so much, Dr. Hershow, for the great presentation. It helped me understand the role of nursing homes in COVID epidemiology and why we ended up with such high numbers of cases and deaths. We can switch to questions. We have a lot of questions. I'm going to start with Megan's question. She's asking if there are any new studies that show viral load is less than initially thought in asymptomatic cases.
No, I would say as a general rule, there may be some decrease in viral load among those who are asymptomatic, but it's not reduced enough that we don't think that asymptomatic cases are an important part of the forward transmission of this virus. And you know, based on a lot of work and sort of a gestalt sense of that work, it appears that about 30 to 40% of transmission events may result from either asymptomatic or very mild infection.
Thank you. We have another question asking, is there a worry about the potential number of global COVID-19 and flu cases being skewed because of the shared symptoms, along with the issues of testing availability in certain areas?
Well, yeah, don't get me started on testing availability. That still remains a problem, and we have to build up our testing capacity. Regarding the influenza season, that's certainly going to complicate things and confound things for us a lot. I think right now, when somebody develops a respiratory illness, it doesn't have this competition where we're thinking it might be influenza. In the fall, of course, we can anticipate the beginning of our influenza season, and that will complicate everything a lot, and will, you know, have a lot of people undergoing a testing algorithm that involves testing them for flu and for COVID-19. There's also some evidence in the literature that being co-infected by two respiratory viruses heightens the chance of a poor outcome or a severe disease presentation. So that's another issue to be concerned about. There is some possible reason, though, to think that this, and I don't want to tout this too effectively because I don't want this to be taken as an excuse not to get flu vaccine. I think we should all avail ourselves of flu vaccine. In fact, we who have planned for the reopening are targeting a flu vaccination rate among our students and employees at 70%, which is way higher than we've ever achieved in any other previous year, in part to guard against this potential confounding effect of influenza on our understanding of our community's epidemiology and what it means when you develop respiratory symptoms. But there are some intriguing things to notice, and that is that influenza season in the southern hemisphere this year has been quite mild. And there's the thought that the same social distancing strategies that work to control and flatten the curve for COVID-19 also have a mitigating effect on influenza. So there may be, if we're good about the social distancing through the fall, we can maybe anticipate a milder influenza season. There is another intriguing notion that one of the ways that influenza has its effect on human populations is essentially by flipping hemispheres. So right now, in the southern hemisphere's winter, which is our summer, they're having their influenza season, and then what happens usually is that there's a certain amount of southern to northern traveling going on, and that some of those travelers flip the hemisphere by bringing influenza with them on their travels to the northern hemisphere. Because traveling is so curtailed right now, that traveling effect is also diminished. The thought is, and that might lead to a milder than normal northern hemisphere outbreak of flu. But again, I want to not leave anyone with the notion that Dr. Hershow is saying that you shouldn't get flu vaccine this year. On the contrary, this is a preeminent concern this year. Please get the influenza vaccine.
Thank you. And I'm going to ask the next two questions together to save some time. So how did China have such a low amount of cases? What did they do differently compared to everyone else? And the second question is there speculation that China is misrepresented the number of cases that they have?
There is some speculation about the lateral, but I think most experts would agree that it's undeniable that the Asian countries, including China, have done a dramatically better job than some of the Western Hemisphere countries, like the United States, like Brazil, are doing against this virus. And part of that is that they they realized early on that the household was an important setting for forward transmission of infection. So they started establishing fever clinics where persons could be removed from their households, maintained in strict isolation, carefully kept indoors and under circumstances that wouldn't permit them to go out and spread the disease into the community. The other thing that China did earlier than we did is promote mask wearing, and that was another mistake, I think, on our part, was to early on not to embrace mask wearing as a prevention strategy. So I think it was that combination of being willing to really, in China, sort of at times children were separated from their parents in these clinic environments where people with fever were being watched before while they were getting their influenza tests and their COVID tests to gauge what they had. And I think that commitment led to dramatically better control. There are examples of countries that didn't go to those kind of draconian measures. South Korea, I think, was much more reliant on on um, on contact tracing and a dramatic upscale and a dramatic scale up of their testing programs, and they got their testing off the ground much quicker than we did. In any event, all of that has translated into better societal outcomes in those Asian countries.
Okay, thank you. Another question from Matthew. Like COVID ranked number 3 in cause of death this year, behind heart disease and cancer. Do you think another shutdown is required to help slow the rate of transmission?
I think to a large extent, in many areas of the United States, we reopened too soon, and that yes, I think that in many states there would be advised to be a reinstitution uh, of the kinds of lockdown conditions that we had in April and May. There, uh, or March and April and May. There are some people that are, there was recently an article in the Atlantic Monthly that talked about a different strategy that would involve home-based testing for COVID, and that if COVID testing could be widely available and people could test themselves every 3 days or so, that they could react to positive tests and really isolate themselves, that might be an alternative approach to full lockdown. But that's speculative, and it really hasn't been an approach that was used in any society yet. So if in fact we start promulgating that kind of home testing for COVID, that will be an experiment. We'll have to see how it works out.
Okay,
so
unfortunately, yeah.
Yeah. So
sorry, go ahead, Dr. Hershow.
I just wanted to finish up that I think yes, in many communities, I think the reopening came too soon, and there has to be a scale back of that reopening.
Unfortunately, we can't go with all the questions, so Christine gonna pick a few more questions for us.
Okay, so the next question is, what are your thoughts about cluster testing in areas with limited testing capacity?
Yeah, I haven't read too much about cluster testing, and I am not well equipped to answer that question. I'll have to take a pass on that one.
Okay, no problem.
Perhaps,
And
perhaps
Amir.
perhaps somebody in the audience or in the class knows something more about that. If so, please unmute.
Yeah, does anyone have anything to say about cluster testing? All right, well, we will move on to the next question from Amir. Would you say we predicted a summer respite due to our assumptions on the virus's behavior, or due to lockdown and similar social measures?
I think some of it was based on our assumptions and by our long-term experience with influenza calming down in the summer months, when people tended to not be in indoor environments, built environments as commonly. What's interesting is that the summer respite the summer surge, I should say, of COVID was particularly profound in our hottest states like Florida and Texas. And some people have postulated that that's because it was so hot in those states that people were driven indoors into air-conditioned environments. So the whole thing may have behaved counter to our intuition about summer being a time where people move out of built environments into the great outdoors and engage in more outdoor activities. Yeah, so we had been used to this idea that when schools are out and people are out and about more, that respiratory diseases calm down, and that didn't really turn out to be the case. We really have to see whether what goes on this fall is even more severe, and whether this will be a new wave of occurrence that makes the summertime pale in comparison or not.
Okay, I think that kind of answers our next question from Megan as well. So I will move on to David's question. He says, what about the quality of the data? There are still many reports of large false positive rates by certain companies and types of tests. The NFL recently got 77 positive tests, and upon retesting, they were all actually negative. Is this concerning that so much of the data could be flawed?
Yeah. Yeah, I think that's one of many issues with testing, is that there are so many tests out there, and the quality of tests does vary a great deal. In planning for the UIC's reopening, we really thought long and hard about which tests to use for the surveillance testing program that we initiated fairly recently. And we came up with a saliva-based assay, a PCR saliva-based assay. In order to decide ultimately whether to use that test, we fully validated it against our gold standard test, which we had also engaged in a lot of research to figure out which the best nasopharyngeal swab test would be, PCR test would be. And we found that our saliva-based test had a specificity of 100% and a sensitivity of 82%, which was 82% perhaps doesn't sound that great, but for a surveillance test, that's quite good. And the advantage of saliva is the specimens are easy to provide, and there's a lot of throughput. You can do a lot of tests per unit using that type of test, and ultimately we selected that. In jurisdictions that haven't perhaps engaged in that kind of careful validation, there may be bad tests circulating, but again, that's sort of the black box of testing in America right now. We don't know a lot about types of tests being used, who's being tested with tests, and we just have to get better at not only doing a lot of tests, but figuring out which kind of tests to use, and to understand disparities and inequalities in access to testing and those kinds of things.
Great, thank you. So everyone in the class, just so you know, some of your questions are very similar, and some I think Dr. Hershow already addressed. Maybe you asked them before he addressed them, so I'm going to jump around a little. So how transparent is UIC being with the number of people connected to campus who test positive? Are they making the number of tests done and the number of positive tests public?
Yeah, there's a dashboard that's, anyone can tune into the dashboard, and it will identify for you how many tests have been done and what the positivity rate is for those tests over time. It also keeps track of metrics like how many isolation beds we have in our dorms. That's a key metric because, as we do contact tracing, first of all, when we identify positives, we place them into, if they're dormitory students, we place them into isolation beds, and we place people who are dormitory students and who are significantly exposed to those cases into quarantine beds that we've earmarked in certain dormitories. We don't have an infinite number of such isolation and quarantine beds. And one of the limits on our reopening is if we ever have a dramatic outbreak on campus and we start overwhelming our isolation bed and quarantine bed capacity, that might be a reason that we have to declare, to scale back our reopening and go to a 100% online kind of environment at UIC rather than the current hybrid environment that we're in. So we're keeping track of those metrics, and those are available on the publicly available dashboard as well. Our contact tracing team at UIC is not just a contact tracing team. In fact, we call it the epidemiology and contact tracing team, because we are not only, we're going way beyond the dashboard in our approach to keeping track of COVID on our campus, and we're following descriptive statistics regarding person, place, and time. So rather than just the crude number of people who are getting infected, we're looking at attack rates in various high-risk populations, like our dormitory students, like our student athletes, our performing arts students, and we're also taking a careful look at the difference in COVID rates among our students who commute using public transportation as opposed to students who commute using non-public means, like some walk to class, walk to the school, or drive to the school, and so forth. We are keeping track. That data is less publicly available, but it is being shared with leadership, and we go over it on a regular basis. Honestly, it's very nascent at this point. As I said, our contact tracing work started on Monday, but those person, place, and time data will be released in the form of reports that will be released over time.
Okay, I think we have time for just a couple more questions here. So what does it mean if someone tests positive even 2 weeks after the start of their symptoms? I've seen a lot of this in the reports that people still test positive even after overcoming the illness. If the test is positive, does it still mean they're contagious, or are the tests just sensitive?
It generally means just that the test is super sensitive, and that people remain positive on the test even though they're not shedding viable virus, that is, virus that's capable of infecting other people. The shedding of viable virus seems to shut down after 10 days. Now, there are some host factors that lead to prolonged viral shedding. For example, immunocompromised persons have been found to have prolonged periods of viral shedding, and that is meaningful viral shedding. That means that those people have to be kept in isolation for longer periods of time. But for sort of normal, healthy adults, the period of active, viable viral shedding seems to turn off after about 10 days from the onset of symptoms. Our general rule before allowing people to return to participation is that they 10 days at least have to have elapsed, and there has to be at least one day without fever and a general improvement in the other symptoms, the respiratory symptoms and other COVID symptoms like fatigue and so forth.
Okay, so are we aware of any data that breaks down positive and negative tests for symptomatic versus asymptomatic people? Could it be that symptomatic infections have higher mortality than is perceived due to number of asymptomatic infections?
I think what we really don't know yet is the overall case fatality rate of this. I think the answer on that will be when we start doing seroprevalence studies for antibody and not virus, not the PCR testing, but the antibody assays that will inform us about what proportion of our population has in fact been infected. And then we will have a reliable denominator to put our mortality numbers over to determine the true case fatality. I think, can you read the early part of that question again? I'm not sure I'm doing it complete justice.
It says, are you aware of any data that breaks down positive and negative tests for symptomatic versus asymptomatic people?
Well, in general, symptomatic people who are tested are more likely to be positive when they're tested than negative people. But in order to get a handle on this, for example, we are ordering COVID-19 tests on those contacts of our case patients, that is the case persons, the persons who test positive on our saliva-based assay. If we find that there are other students or faculty that have been exposed to those individuals, we will order a COVID-19 test, and it's not the saliva test. We send them for the nasopharyngeal test, which is a little bit more sensitive than the saliva-based test. And we're doing that to try to get a sense of how large our asymptomatic group is, and also to get some sense of whether our contact tracing is working. A key metric in contact tracing is what proportion of newly identified cases are identified by contact tracing. So the metric for that would be the proportion of new cases at UIC that in fact were identified precisely because our contact tracers found them and instructed them to go into quarantine. And then at day 5 to 9 of their quarantine, we're testing them to gauge whether that in fact they did or did not have COVID infection. We still don't trust the test enough, even at that 5 to 9 day period, to allow them to move out of quarantine if their test is negative. So those quarantined individuals will stay in quarantine for the full 14 days, but it helps us to get a sense of, in fact, whether those people who remain asymptomatic in quarantine have developed infection.
Thank you. So let's do one last question here. Looks like it maybe is asking you to hypothesize if there is a situation where a lockdown would return. I'm not sure if they mean here in UIC or in Illinois or the country, but is there a situation that you could see a lockdown returning?
Yeah, I like I said a little earlier in this talk, our eyes are on the fall now, and we have a more reopened society. That includes college campuses. To some extent, it includes K through 12 education. In Chicago, of course, K through 12 education is being done remotely, but that's not true in other jurisdictions, as I think everybody knows. So we're keeping a really careful eye on that. We're still not sure of how important children are as transmitters of infection. So that K through 12 group, we're still a little unsure. There's data that suggests that perhaps very young children may be less efficient transmitters, but that children over age 9 or so sort of transmit as effectively as adults do. So, if there's a terrible fall wave, that could throw us back into lockdown conditions. I hope it doesn't happen, and I hope that this combination of face mask wearing, continued social distancing, limited reopening, and sensible behavior and avoiding congregate settings in built environments will keep our rates low. We've seen sort of an overall downturn in incidence since our periods during the summer, but we really have to watch the fall carefully to see what happens.
Okay, well, thank you so much. That was all very insightful. I think that's all the time we have. I will turn it back over to Dr. Forst. I don't know if you have any class announcements or anything, Dr. Forst, but thank you so much, Dr. Hershow. We really appreciate you being here.
Thank you, Christine. Thank you, Sinan, and
Thank you, Dr. Hershow.
Linda, is your audio working?
All right, well, I guess that's it for the class, everyone. Thank you.
Thanks again for inviting me to give the talk and for your excellent questions and being an attentive audience. Really appreciate it.
Thank you, Dr. Hershow.
Thank you. Bye, everyone.
Thanks, Christine and Sinan.